and it was truly inspiring, and hope that from this talk we would take baby steps forward. So I just put a couple of, questions which we would have to maybe kickstart neurocritical care in low middle countries, income countries. Mm, and at the outset, Rani ma'am has given a wonderful introduction, but I would also want to give a small introduction. Nishad sir is my teacher, my professor at JIPMER, where I did my DM neonatology, and always an honor to interact with you, sir. Uh, Dr. Nandakishore Kabra needs no mention. He's from Surya Hospitals, and we know the tiniest of babies from India survive over there. Again, an honor to interact with you on this panel, sir. And of course, Dr. Khurshid, I put up this from the Newborn Brain Society, this picture, which is small brains and big dreams. Very apt for his neurocritical care and for this. And thank you for being here and also on our panel to answer our questions. So without much further ado, I'll go to the objectives. So the objectives are now to discuss the current landscape and challenges of neurocritical care in low middle income countries, and also what we can do to innovate, and also see whether there are any success stories in LMICs, and also for exploring collaborative models and formulating actionable recommendations. So the first question is to Dr. Nishad. Is there really a need for neurocritical care in India?
Hey,
So
Bharati, thank you. So for this question alone, I thought this was kind of a key question, and everything else that follows depends on this. So for this question alone, I have a few slides. Can I share them?
yes, I will stop sharing.
Okay, are you able to see the slide?
Yes.
Okay, so I have a bit of an unexpected answer to that question, and I'll explain why before you tear into me for that answer. My first thought that came to my head when I saw this question was no, and that had something to do with the question being about India as a whole. But then I think yes is an equally valid answer to that question. And I'll explain why in a moment, because when we speak about India, we have this variety of healthcare systems across the country. So this is from our National Family Health Survey, NFHS 5, 2019 to 2021. The neonatal mortality where Dr. Rani works in Kerala is 3.4 per thousand live births. And where I work, it's around 2.5 or something like that. And for comparison, that actually is quite comparable to what it is was in Canada around the same time. So this is one end of the spectrum in India. But we also have large states with much higher populations than Kerala, with 10 times the neonatal mortality rate. And so this creates a problem for us because do we really think that the same interventions would apply or the same priorities would apply in these two different states with widely varied facilities with widely varying neonatal mortality rates? I think our priorities should be different in different areas of the country. If you want more recent data, this is just from this month, and it was published a few months ago online. And we were looking at sepsis in district hospitals in India, 5 district hospitals, one in south, one in the east, one in the west, one in central India, and one in the northern part of India. So these were geographically distinct parts of India. And I just want to point out the data from one particular table. So site 1 is the site I was mentoring not far from Pondicherry in South India. This was the largest site in terms of enrollment. We enrolled about 1,700 infants there. 10 had sepsis and none of them died. So this center has 6 pediatricians. They have round-the-clock trainee support. There are people on duty. They can do lumbar puncture. They can do long-term mechanical ventilation. They are for all practical purposes a level 3 unit. This is a district hospital. Site 2, the second largest center, had almost 10% of rate of sepsis. Almost 10% of the infants enrolled in the study there had sepsis. And half of those with sepsis died. So this was in central India. So these are the two extremes that we are talking about when we talk about India. So I think yes and no both would be good answers. Where Dr. Rani works, for example, I was in the city a few years ago, and in one street there are 3 or maybe 4 level 3 NICUs. And in this particular part of central India, in that NICU, the SNCU, the Special Newborn Care Unit, they actually had a person who had completed maybe 1 year of DCH, who was a part-time pediatrician available for part of the day. So there was no 24/7 coverage or anything. So is a neurocritical care unit a priority there? I would pretty confidently say no to that. I mean, there are a lot more problems there that need to be sorted out before we talk about neurocritical care. So the answer, in short, Bharati, is yes and no. Yes, in the sense that we have a need for it, definitely. We have a high burden. We have about 13% prematurity rate that translates in India to more than 3 million preterm births. That's more than the number of total births in many countries. Large burden of asphyxia, sepsis, meningitis, and of course congenital anomalies. And there is the economic cost of disability to be considered, but this is not the low-hanging fruit. I think the mortality reduction is still the priority in large parts of the country. So I think yes and no are both valid answers depending on which part of the country you're sitting in. That's all I have for that question, Bharati. I'll stop sharing the screen now.
Yes, sir. I think that is very aptly put, very concise and very precise. And I would agree with you on this that yes, we have to see priorities where we embark on things. So the second question is, I just put up these slides, sorry. To Kabra sir. So how do you think neurocritical care in your scenario could change the landscape for the tiny babies?
Thank you for the opportunity. Now, interestingly, when I was listening to Dr. Khurshid's talk, meaning 2 years are passed by where we have not pulled any baby in our unit at all. No asphyxia, and completely the obstetric care has improved so much so that most babies are inborn and predominantly preterm. When I think in terms of my unit scenario, I think of preterm babies who are actually having, say, grade 3 or grade 4 intraventricular hemorrhages or periventricular leukomalacia, and some of them with IVH ending up with hydrocephalus requiring reservoirs and shunts. So what putting this protocol in place will help with its early detection, identification, diagnosis, and getting the multidisciplinary team on board so that whatever damage is already happened can be prevented further. Now, suppose we develop these kind of protocols in tertiary care centers and generate some data that by doing these interventions, we are able to improve the outcome and also able to train some of the trainees who are coming to us as a fellows for IAP, NNF or DNB programs and generating more workforce to look after these kind of babies. Eventually, the whole goal is to reduce the burden of childhood neurodisability.
Totally agree, sir. And I think that was also very well articulated and very well put that, yes, as smaller and smaller babies are surviving, we should look beyond survival. So survive, thrive, and transform should be our goal. And yes, for them, saving their brains is going to be very, very important for their short-term and long-term outcomes. So to Khurshid sir, this question, I think you have already addressed this, but then if we have to jump into neurocritical care as of now, given the landscape in low middle income countries, what do you think are the basic core components we should address? And the second question is, how did you get nurses on board, and how did you manage to get separate infrastructure and separate human resources for establishing neurocritical care?
Thanks, Dr. Bharati. I want to congratulate Dr. Kabra. I need to learn how you prevented HIE because it should be the ultimate goal for human beings. Maybe we can talk offline the things that you have done with your OB. The one thing to Dr. Nishad's very, very valid point, when we started here at first launching kickstart of the program was a mini symposium. So mini symposium just announcing that this is happening. We had a guest speaker who was my mentor in Vancouver who taught me MRI, Ken Poskett. That guy was so good. He refused to be paid for his flight. He said, I'm paying for my flight. I'm paying for my state's principal. He came, he gave us talk. We had our key players presenting as well. But the point I want to make there is one of the very senior neonatologists stood up in that meeting and he or she said, I have been taking care of HIE for decades. And now you're coming telling me that I need a program to be able to look after my HIE. This is nonsense. And English being my second language, I didn't feel the insult. And I went back home and my wife was telling me, are you okay? I said, why? She said, I get phone calls that you got insulted today at the symposium and somebody was very abrasive to you, etc., etc. But time fast forward, the same person started to seek our consult because that person saw the value of the unit and neurocritical care. The second, I made a couple of trips just as you have a product, you want to sell it to other people. I went to centers like Edmonton, Sickets, just selling the idea of unit and neurocritical care. And some of the replies I would get to say, at the beginning of the meeting, they will open it up, how can I help you? And then they'll say something like, I'm not in the position to dictate on other program how to train their fellows in unit and neurocritical care. This is not happening. So it's always there. And I always think we switch our mindset from seeing is believing to believing is seeing. When you believe something, you make it happen because people eventually they will see the passion, they will see through that your point of mortality is valid, Nishad. It's the same problem in Canada. You know, in the Northern Territory, the mortality rate is so high and the care is so different. And that doesn't mean those are competing interests. Because if there is somebody passionate like you or Rani wants to run the neurocritical care program, so would be. Because what we showed in the implementation, the mortality was reduced. The rate of brain injury was reduced. The rate of missing HI was reduced. Those are all priority, even in India, that having decreasing the rate of HI is a priority. For example, in sedation use was reduced. So to your point, Dr. Kabra, about the micropremies, there was another big project that we have been working on for more than a decade now called Drive IVH to Zero. And there, the first, when I came back, my task was to update our post-hemorrhagic ventricular dilatation protocol with neurosurgeons. So when I came out from that meeting, it became clear to me that return on investment following this is very little. And I went back to my section head and I said, I am putting this on back burner and we rather work on IVH prevention to prevent this problem from happening. And it was so good that one of our neurosurgeons, when they saw me in the hallway, said, either your phones are broken or this IVH thing is working because you guys are not calling us anymore. So it works. It works for tiny babies. It works, and that's the magic of quality improvement. It doesn't require fund. To your question, Dr. Bharati, it requires people. Is the hardest thing because it's hard to convince people. But once you have them on board, they will give you their lives. And that goes to the nurses. Nurses, they don't care about publication. They don't care about grants. They care about babies. If you are genuine enough and if you are able to convince them that this your intervention will make a difference for this baby, they will put their lives online. Imagine NICU nurses learning how to put EEG on. They have never done it. When we did the IVH prevention, the drive IVH to zero, part of it was minimal handling. They were guarding the incubator to the point that I would get complaint from neonatologists saying that your nurses are not allowing us to examine our babies anymore. Like they are that good if you are able to convince them. And then you pick up core competency. And what I would say, you can make a fancy name for it. So that's another story I want to tell you. When I came here again, they sent me and one of the pediatric neurologists to one of the big centers in America to learn the neonatal neurocritical care components and come back and establish the program. I think we spent about $1,000 fee for that day of service, of training. And when I came out of that meeting and I told my pediatric neurology colleague, I said, we have all this. We just need to go and reorder our house and put a label on it and just start working. You can name it. You're probably doing neonatal neurocritical care. You're just not labeling it and put a fancy name on it. I think you are there. I think you have, from the cases that we are discussing together, from the care that you are providing, there's something that's practical, that is important to put priorities, but there are standards that we should always aspire to. Like if we don't have a goal that we need to aspire to, we don't have an example and role models, we will live in status quo. We need to eat every day. We need to go to our work every day, but we need to have dreams. And I think without dreams, we won't move forward. I know it's very philosophical answer to your questions. Lots of self-funding at the beginning. Your last questions, we're paying from our own pocket. We will have a group funding ourselves. The head ultrasound simulators, first time we asked our section to fund, they didn't see the value of it. So we ended up paying it from my own pocket. And now look at the simulators that we are using it everywhere in the world. You need to show the value to get buy-in. So at the beginning, there were lots of self-funding, self-belief. Once you publish, once you see the value, then funding and grants come in and they will support. One of the reasons we wanted to establish neonatal neurocritical care and formalize it, standardize it, is to make it easier for the program to seek funding. If you have it accredited in the US, if you have it accredited in Canada, when you as a program director go and ask for funding, it's easier when something is accredited as compared that something you are building from scratch. And also it's making job for the new generation. There was no neonatology in the past. Somebody thought of creating the neonatology field so you and I can work. So when our offsprings come to the world, we need to create new jobs for them. And that is why with TNE, with POCAS, somebody's thinking of something else in pediatric and others. That's how we build the future for the new generation.
That was again truly inspiring. So if I have to tell it in a few words, I would say perseverance, passion, patience, and probably a lot of publications would help convincing putting neurocritical care together, if I am right. Thank you so much, Dr. Khurshid. Moving on to the next question. What are the barriers and facilitators we can anticipate in the public setting where Nishad sir, you're working, and what are the same in the private setting, Kabra sir? So the first question, Nishad sir, I have your slide with me, so I will share it if that's okay with you.
Yeah, go ahead.
Yeah.
So I work, as you know, in a publicly funded unit, which is large and predominantly caters to poor patients, I would say. So, but surprisingly, money and infrastructure maybe are lower down on the list of barriers because it's increasingly easier to get something built. If you want a new unit built, it will take time, but it can be done in the public sector also. You can get funds for equipment, you can get funds for buildings. The one thing that is really, really hard to get is human resources, particularly nurses, and they are so critical to any program. As Kharshid was pointing out, to neurocritical programs or care programs also, but even the routine in ICU, it's hard to get them to approve manpower. It's also hard to retain trained manpower. So nurse turnover rate, in spite of not having a transfer policy or not transferring routinely, is about 15-20% a year. So you train nurses and they leave pretty quickly. Many of them go abroad, so there is a brain drain also, but then also they join from different parts of the country and move back to places closer to their home. So there is still a lot of mobility. There is a lot of so this relates to probably income discrepancies in different parts of the country. People tend to move around a lot more, and nurses tend to move around a lot more in our country. So I think human resources are a critical barrier. And it's not just nurses really. So we have an MRI machine, a 3 Tesla MRI machine. But the question is, who interprets the MRI? When we were second year fellows, I think Harshid went and did a neonatal neuroradiology fellowship. And we had some online classes from his mentor. And when he came back also, interpreting MRIs was drastically better. So there is a value to that knowledge and that training that we don't have. We don't even have a pediatric neuroradiologist. So having a machine is infrastructure, but having someone to interpret it is another issue. The same way, we have neuro surgeons, but sometimes they would say, wait till the baby is about 2 kilos. The baby is too small to operate now. And you know what happens if there is a post-hemorrhagic hydrocephalus and it's expanding. You can't really wait until it's 2 kilos, until the baby is 2 kilos. So it takes a whole village. But as Kharshid was saying, you can still take small steps. We have a lot of things in our favor. One is that we don't have a shortage of neonatologists currently, at least in most parts of the country, because we have, apart from DM courses, we have so many fellowship courses. In fact, in some places, I would say there is an excess of neonatologists. So in that sense, human resources are not a problem. Trained neonatology doctors are not a problem. We have a policy focus. The government is pretty focused on treating disability, identifying it early intervention. They're all part of various programs. So incorporating something like this into the policy is not a giant leap. There is already a focus on these things. So preventing or improving neurologic outcomes and preventing disability, that's definitely a part of the government's focus and can be incorporated. And we also have excellent training programs like facility-based newborn care training programs and others. And at least after COVID, everyone's used to telemedicine in the country through WhatsApp and through other things. So we have many points that are already existing that will help us to implement something like this. So it wouldn't be a stretch to say that this can be done, but it will take someone with a vision to take it forward in each place, maybe, and in each sphere, maybe public and private separate differently. The challenges are very different. Maybe we can clone Kharshid or something like that would be needed.
Very well put, sir. Now for the barriers and facilitators in the private setting. Kabra, sir.
So Nishad made my job easier. He broadly broke the barriers and facilitators into several categories like workforce, infrastructure, integration of the care, public awareness, presence of protocols, and self-sustaining the program. In private sector, one of the issues is going to be if we involve multidisciplinary people, obviously the cost is going to escalate. And finally, if the cost escalates, we have to show that that increased cost is giving some added benefit to sustain the whole program. But in principle, like I think all these barriers can be overcome by engaging the whole hospital management and involvement of the parents and self-motivating ourselves to sustain it in long term.
Thank you, sir. So I think the theme of barriers and facilitators is that again, we need a very passionate team of people who is going to take this forward, either both in the private and in the public setting. Coming to the last but one theme. So how can LMIC scale up training of staff and neurointensivists? Nishad, sir.
Yeah.
Yes.
So this almost certainly will need a public-private partnership at a scale that we haven't yet done for other things. So the government has, when it comes to more advanced things, or the programs that affect smaller and smaller parts of the population, the government involvement is going to be less and less, because they are probably going to be more focused on programs that will benefit larger chunks of the population or have a greater impact. So, but we do have organizations like IAP, we have organizations like NNF, the IAP Neonatal chapter that's organizing this talk. So, and in states like Kerala have shown us how wonderfully public-private partnership can work. So that will be one key element of training neurointensivists and ICU staff, that the programs will have to be established with the public-private partnership. Another is, of course, mentorship from established programs. As Khurshid said, that's how he was able to start it. He did get trained somewhere and came back and established it. And continued help from other centers would have been there for the program to be successful. So, and just as we are now picking his brains to try and establish these programs ourselves. So mentorship from established programs is actually easily available. And thanks to people like Harshid, there are already online resources available. There are training programs available, and formal fellowship training that, like the one he has established, would be probably the last step. But yeah, I think that is going to be a stepwise approach to scaling up the training.
Thank you, sir. And to Khurshid, sir, how can international collaborations or tele-education play a role in scaling up training of human resources for neurocritical care?
Yeah, thanks. I think the Nishad's point, I'll pick where he ended, is the mentorship. Some of the online modules that we put together, it has allowed the option of long-term mentorship. And I think people who are sitting here, they are all leaders, and they can move mountains. We just need to believe that this is important. We can take it on and move with it. SCAN program in India is a good example. It started with Smesh and Prashant and the group from Calgary, and then they took it to a next level right now, and they are training lots of centers in India. It's completely independent, a wonderful program combining in-person and online. Something similar can happen with the neonatal neurocritical care, starting with the available resources and then building upon it. Now we know what the core competencies are in neonatal neurocritical care. And that is a good start, and creating a long-term mentorship training program, combining empowering the local instructors and then working remotely with mentors to start with, and end up with some formal training for champions who can come back and establish the program in India. And you know about the Newborn Brain Society India task force that Kirti is leading. They have done also wonderful work with the weekly webinars and some of the works that we are doing. There's lots of things that's already there. We just need to put the pieces of the puzzle together and put our heads together and get it going.
Yes, thank you, sir. And every time I do go to that NBS website and the neurocritical care course, every time I have a doubt or anything, so it's like always readily available online, and it's very, very useful resource, I should say. So the last theme, like, what would be a low cost, high impact intervention according to you, like one Kabra sir, one protocol or one equipment or one strategy? And do you think that telemedicine or mobile technology can change care delivery, especially related to neurocritical care?
Dr. Khurshid's talk was self-elaborative to answer this question. Meaning,
Okay.
suppose you have to deal with one disease, it would be therapeutic hypothermia, whatever way you use it, he gave with limited resources with the best possible high-tech things. And because it's a high impact, critically protocolized, and it has also shown that it actually works. Equipment, if you have to invest in, now we all say when you say neurocritical care, automated EEG. Now in India, there are these cooling devices have been developed in Bangalore called Revive, in which they have inbuilt automated EEG along with the cooling system. I think Chandigarh is going to use those kind of systems. So basically, it will help detecting the seizures even before they manifest and prevent the brain damage. And then strategy is like going to be training people, training more people, making them local champions, and these people will motivate more people and take it further. Post-COVID, as Nishad told, telemedicine and then video conferences and these various different platforms have been used widely. In the beginning, you can use it for identification, then diagnosis, treatment, either remotely or help with the transfer. So telemedicine has, we can work as a mentors to people who are approaching us, say for example, I think in St. John, Bangalore, you are already mentoring people in various SNCUs for various things. You also develop program for managing retinopathy or prematurity. The same thing can be incorporated by utilizing the telemedicine.
Thank you, sir. I think that was very concisely and aptly put, that HIE, therapeutic cooling, and telemedicine, that is mentoring SNCUs, would be a way forward of low-cost, high-impact interventions. Now to discuss the last theme, that is a path forward. Now, what bureaucracy or collaborations is anticipated to take this forward for private organizations like us? And Nishad sir, for government organization and institutions, how we can make governments or ask them to prioritize neurocritical care? First, these two questions. First, Kabra sir, yes.
Yeah, so Dr. Khurshid's slide about collective leadership was very inspiring. So it's everybody's baby, so everybody is deeply involved, whether it is a neonatologist or a pediatric neurologist or a neurosurgeon or your neonatal nurse or your developmental team and the multidisciplinary team. So who need to collaborate and take the ownership to take this movement forward. Then the second thing is like sometimes there may be differences of opinion which can be sorted out with discussion and targeted policy development. And then IAP or NNF or these professional bodies can utilize the resources that have already been developed abroad and develop the framework that can be used in Bharat as well as India, the rural setup and urban setup, so not so developed and very well developed centers. So that would be my take.
I agree, sir. And I think the key would be also to involve IAP, NNF, and organizations to help us support this forward. Nishad sir, over to you.
Yeah, Bharati. So one thing that we have done successfully in the last decade or two is, for example, streamline the approach to respiratory distress. Extensive use of CPAP. The devices have been made available. People have been trained. And it's now part and parcel of treatment of respiratory distress in every SNCU. So we have more than 1,000 special newborn care units across the country. They are level 2 units with varying levels of facilities available. But practically everyone is able to give support for babies with respiratory distress. So incorporating something like this into neonatal care is quite possible. It just needs some refocusing on the part of the government and organizations like IAP and NNF. But it's since we already have a well-educated, well-trained, legion of people across these SNCUs. Implementing this is still possible with some change in the focus and by incorporating these principles into the current guidelines for neonatal care. Another thing is that has changed in the last decade maybe is the insurance rates, especially in the last 5-6 years, have gone up dramatically. State governments are providing insurance, and of course, there's the Prime Minister's insurance scheme. So even in JIPMER, this has been a sea change that many patients now can afford to get treatment, for example, for various respiratory conditions for free, and even get consumables and drugs through the insurance scheme. So if the focus is on improving neurological outcomes, we may need to include more conditions specifically in the insurance schemes if everyone is able to access it. And of course, innovation is very important in a country like ours and low-cost devices. So 5-6 years ago, 2 people had approached us for inputs for a cooling device. And that is the device that Dr. Kabra mentioned, the Revive made by Sensivision. In fact, they had spent quite a lot of time with us in JIPMER and had offered to give us a free device also as part of, because we had given them a lot of inputs in the creation of that device. So, and there are now multiple other companies working on those things, and at least 3 or 4 companies that are working on these things, and 2 devices at least that are in the market. They are the results of local innovation, and at a fraction of the cost of Western devices, about 1/3 to half the cost of Western devices for cooling. And of course, we need to at least do some pilot projects, neurocritical care programs across maybe in selected parts of the country. One thing we really don't have a handle on is what is the cost and what is the cost effectiveness of these programs, right? So that those pilot projects would be able to generate those kinds of data and other metrics also. We can keep track of QI, can be used to keep track of other metrics. We already have many QI programs in this area related to the incidence of asphyxia. For example, CMC Vellore and other centers have shown us how QI can dramatically reduce asphyxia itself, mortality, infection. So I think data will be another thing in convincing government to change, especially cost and cost effectiveness.
Thank you, sir. And I think to summarize that, it would be low cost innovations and cost effectiveness and small QI programs are the way forwards to convince the government. Last question to you, Khurshid, so that were there any of these models which you had told us got integrated into the healthcare system of Canada? Were they sustainable to other parts of Canada as well?
Yeah, I just want to share one slide actually to Dr. Kabra's point. Can you see my slide?
I just stopped sharing.
Should I?
Yeah, we can see.
Sharing?
Yes.
Yeah, so I think this was interesting when you're talking about sustainability, and this was the graph on the top left is from our IVH prevention paper. And it was interesting, after the intervention, the rate of significant IVH dropped significantly, but the variability took time. So with any QI intervention, you will see change, but that the variability in the system will take some time. And it was only here where the change became the new norm. the first thing comes back when you just take your eye off the ball is not the rate, the variability comes back. And that's always a warning sign that something went wrong and you need to go back to the drawing board and revamp your intervention. So for anything to be sustainable, it needs to go over time to become the new norm. And some of the examples that got integrated into the Canadian system is the cooling on transport. Now more and more centers are using the servo control devices for cooling on transportation. The IVH prevention bundle has become it is national. Most of the centers, they use one version or another from the IVH prevention. The outreach program also has been integrated into our system. And then the continuous video EEG, most of centers still use amplitude integrated EEG, but the more and more centers are collaborating between pediatric neurology and neonatology to combine both technologies together and make it one. And one thing also was mentioned about it's everybody's baby, and that I find is one of the challenges. After you have done something for long, it becomes your thing. They say, oh, your bundle is working or your bundle is not working, and we have to resist that idea and then push back on it and say, as you mentioned, Dr. Cobra, that it's everyone. The QI is everyone's job, it's everyday's job. You can't say the bundle worked and I am done with it, or this intervention worked and I'm done with it. It takes only 1 week or 2 weeks for taking your eye off the ball for your rate to come back. It's every day-to-day job. And I think it's the way I think it works best is to have active listening. For example, when we had our inotropic stewardship as part of our IVH prevention, we were accepting lower blood pressure. And there was concern from the team that if you are accepting lower blood pressure, then the ischemia rate will increase. So you will have more cystic PVL, more ischemic white matter injury, which is fine. We'll use that as a balancing measure. So listening to others, that it's helpful because they can open your eyes on some of the balancing measures that you can use to keep your quality improvement project balanced. It's not pushing the pendulum one way or another. So I hope I answered your question about some of the examples. One of the things I find from people who are coming from the resource limited country like us, we have lots of resiliency. We can troubleshoot problems in a creative way where people who are born and raised here, they are stuck in the system. And that makes us move much, much faster.
So thanks a lot. I think that was the last of my questions to the panelists. And if I were to summarize and to conclude, what we need is we need to have patience, perseverance to establish, and leadership to establish neurocritical care. And it's already existing in front of us. We just have to put the pieces together and move forward. Thank you to all the panelists. I hand over the podium to Rani ma'am for answering